So Dr. Perry Sheffield is an associate professor in the Department of Environmental Medicine and Public Health and the Department of Pediatrics here at Mount Sinai. She's also a member of Mount Sinai's Institute for Exposemic Research. Probably didn't say that right, which studies how environmental exposures affect health, disease, and development, and the Transdisciplinary Center on Early Environmental Exposures, P30 Course Center of the National Institute of Environmental Health Sciences. Dr. Sheffield is co-director of the New York State Children's Environmental Health Center, the first such statewide network in the United States. She also serves as deputy director of Region 2's Pediatric Environmental Health Specialty Unit, a U.S. Environmental Protection Agency and CDC and program that provides environmental health services to communities in New Jersey, New York, Puerto Rico, and the U.S. Virgin Islands. Dr. Sheffield's research focuses on climate change and human health, with a particular emphasis on children and workers. She's authored more than 70 peer-reviewed articles and chapters focused on extreme heat, air pollution, and children's environmental health more broadly. She's spoken internationally and nationally and is an advocate for public policy that protects children's health. She co-chairs the New York State Climate Impact Assessment Health and Safety Team and is a member of the U.S. Environmental Protection Agency Children's Health Protection Federal Advisory Committee. She's also co-directed Mount Sinai's Clinical Climate Change Conference on the impacts of climate change on health. And nobody could have sat through last night's thunderstorm without freaking out and trying to figure out what was happening in our environment, and the heat wave over the last few days hasn't helped. So Dr. Sheffield, tell us what's happening and what we can do as family docs.
Thanks, Dr. Kalman, and good morning, everybody. It's a pleasure to be here. I was really excited to get this invitation to present to you all and to start a conversation that I hope will go beyond this presentation today, and how we can work together and how we can bring more climate change training into the residency program and into family medicine in general. So thank you. As Dr. Kalman mentioned, some of the programs I work with are funded by CDC, specifically the ATSDR branch within that, and EPA, as well as our New York State Department of Health that funds our statewide network that I'll say a little bit more about. And Exposomic, as you said, the Institute for Exposomic Research is one of the hats that I wear, memberships that I have as part of the Department of Environmental Medicine and Public Health here at Sinai. So I hope that you all will be able to, if not already, by the end of this talk, articulate some core concepts about climate change and health, describe several examples of climate-related adaptations, I'll call them, for clinical practice, how we integrate that into sort of the preparation and prevention part of this work, demonstrating how clinicians can advocate for mitigating climate change contributions, both from our communities and from our health systems, and characterize the special implications of climate change for minoritized populations that are already facing many health disparities, and additionally think about strategies to improve structural determinants of health that are driving those disparities. So you probably have seen this bug now in New York. This is the spotted lanternfly. And while we don't know that its introduction or spread in the United States have been directly related to climate change yet, we think there's lots of work that now projects that fighting them and fighting this invasion, they are not harmful to humans, but they directly, but they are destroying many crops and particularly trees, fruit-bearing trees, for example. And these are the two life stages of the same insect. They're quite beautiful, and people are squashing them and apologizing all over the city. But one example of how climate change with its warming temperatures are now facilitating the spread of this invasive species and how ecosystems are having to adapt. Another example is pollen season. Many people probably noticed that this was one of the worst pollen seasons, and there's several ecological reasons why we're experiencing worse pollen. And one of those has to do with just more days that plants can grow. As you can see on this map, the green dots, and the larger the green dots are, represent the more days now of frost-free seasons over the last 40, 50 plus years. And you can see that the generally in the more northern latitudes, well, you can see that there's variety, and that some of it is sort of even within the same state, you see variety. And so some of that has to do with a microclimate. And that's one of the tricky things when we think about climate change, that there are, it's a global phenomenon with very, in some cases, very hyper-local impacts. There are a couple of other reasons why pollen is getting worse, and some of that has to do with interesting plant physiology, which has to do with when there's more carbon dioxide in the atmosphere. Now, this is not up in the high atmosphere that's sort of causing the warming, but actually down here in the area, in the level of the atmosphere where we breathe and live, but where the plants live too. Most plants actually are carbon limited. And so when there's more carbon in the air, they uptake more carbon, and that changes sometimes how it fertilizes them effectively. And they can grow bigger, and sometimes they can produce more pollen, and sometimes they can produce more potent pollen. So there's some really interesting work that's looking at that and understanding why allergies are potentially getting worse under this changing climate. And then to pivot, still thinking about air quality, but to pivot to a global example. This photo actually I took a few weeks ago as my family, culminating a visit to extended family in Jakarta, Indonesia. We drove into the city for the first time. This is the second largest, second most populated urban area in the world. And as we drove in, I noticed this yellow sky and saw headlines just the following day that the municipal workers in Jakarta were asked to work from home, not because of COVID, but because they had decided that the air quality was so bad and predicted to stay so bad for the next couple of weeks, that they were trying to both reduce traffic to improve the air quality, but also to protect people from being outside in this air. And while this is a sort of multifactorial phenomenon, right? We know that urbanization is increasing globally. We know that our dependence on fossil fuel power, as you can see, this oil truck that was passing us on the highway, means that when we have higher electricity demands or higher vehicle demands, we are producing more particle pollution in particular. In the setting of warming, more sunlight and warmer temperatures, a lot of those gases get then converted into ozone, and we have smog days. And then we also know, pivot here, next slide, that there are wildfires. And while we think of wildfires mostly as a Western US phenomenon, we in New York on June 7th and 8th of this year experienced our very own sort of wildfire smoke days. This was a frenzy of activity for our team because we were getting questions like these on the slide. Can my child go to school? How about the end of the year field trip? What about gym, recess, after school sports? Do my child need to wear a mask outdoors now? Flipping this around, before we were thinking about it indoors. What kind of masks? Again, we're thinking, do the surgical masks make any difference? What is an AQI, and at what point do we take action? How do I use it? And the question was, are the providers ready to answer this? So in response to that, I also will just sidebar, I think as we drove into Jakarta a few weeks ago, I had sort of I'm not sure that I would have picked up on the color of the sky as so clearly as having experienced it in New York City. And there was a sort of a gross similarity between that orangey appearance. So what we did as a team, as a pediatric environmental health team, working with multiple partners, was to turnaround, sort of rapid messaging. And one clinical adaptation to climate change is to be able to mobilize and have rapid response messaging. So getting more ready for the unexpected. And this took a full team, a full day to really find the right messages, make sure they were make sure they were accurate and tailored to our to the situation at hand. This included physicians, air pollution exposure experts, our partners at the Department of Health to make sure that we were messaging in concordance with some of the broader governmental messages that were going out. And there was a high demand for this information, and it was subsequently distributed by Sinai, by Northwell, by Boston Children's Hospital running the Hudson Valley some of the healthcare facilities up there, as well as the Assistant Secretary of Health, Dr. Admiral Rachel Levine. And so it meant that these reached over 1 million people. And this is one part of the work that we do, the acronym that we call ourselves is NICE Check, New York State Children's Environmental Health Centers. We've taken some poetic license with that acronym, as well as the PACU, our national network. So NICE Check is the statewide network. PACU is a national network of pediatric environmental health experts. And there are many medical organizations that have realized that climate change is an issue and have made statements, policy statements, position statements, urging action, both to prevent in climate language, that's mitigate, as well as prepare, and in climate language, that's adapt. So preventing the upstream climate change from happening or getting worse, and preparing sort of the climate change that is already happening or in the pipeline, preparing for those effects so that we can protect our patient populations. On the bottom, so you see all of these organizations have statements. You can see down on the bottom, the 2019 call to action was then subsequently signed by 100 or so other healthcare organizations. I'm just showing you a sort of a spread of their logos here. Many, and so many are heeding the call, if you will. And for good reason, because the healthcare sector bears a lot of responsibility for climate change. We are actively contributing. The US healthcare sector alone is responsible for almost 5% of global carbon emissions. And there are some healthcare professionals who are really trying to amplify this message and also think of creative solutions. So some of that has to do with things that fall typically outside of clinical, certainly clinical work, thinking about the transport, thinking about the carbon footprint of the food that gets consumed, and the sources of energy that are being used at healthcare infrastructure. But there are other things that are a little bit more in our clinical wheelhouse. And Jody Sherman, who is who co-authored the article you see here, and is an anesthesiologist up at Yale, has been a leader in helping to tell the story and also advocate particularly around anesthetic gases, because it turns out that some of them are highly potent greenhouse gases. And so when those are just off-gassed or released into the atmosphere, they go up and blanket like carbon dioxide does, but have even more of a potent insulating effect and sort of put the warming on fast forward. And there are substitutes that can be used that are less potent, and there's also engineering practices that can be used to prevent as much leaking as happens typically around an institution of these anesthetic gases. And other healthcare systems outside the United States are doing a good job of quantifying what I say are ins and outs. There's some parallels with clinical medicine. Here, the National Health Service of England has shown their carbon emissions by proportion. And so you can just, looking at this, get a sense of sort of where there are wedges of potential action, some people call them. And a lot of that has to do with, as I mentioned, sort of the medicines and the medical equipment but then also sort of the personal travel of the healthcare personnel themselves, and then what goes on in the buildings themselves. For those of you who see water and waster there, I thought that was a special British term. I spent a lot of time trying to figure out what that meant. It's just a typo on the graphic that I borrowed. So don't waste your time looking for it. It's water and waste, as in wastewater. And then some of the policy statements from the professional organizations, this one here from the American Academy of Pediatrics, specifically call for more education and training on climate change in across the training spectrum, but specifically call out residency. And I know that's a specific interest for the leadership in this department. And I'm excited to give you some examples and hopefully inspire that and have further conversation with you on this. And when I give talks on climate change, I often sort of do this pause moment, or I open with this, and to remember that when we think about our world, it warrants a sense of wonder. This is an incredible planet that, because of some very specific conditions, is able to support life. And the current astrophysicists thinking about the origins of the universe and this planet being the third rock from the sun are really phenomenal, and in terms of sort of what had to happen to make it possible that we're here in the first place. And it's that same chemistry that is now getting a little bit out of whack, if you will, because of human activities primarily. So there's other forces that are outside of our human activity, certainly, that are contributing. And those in turn are affecting that very thin orangey line, which is the Earth's atmosphere. It's that blanket of gases that make the difference between whether or not the average temperature on Earth would be as low as negative 18 degrees Celsius. And so it's the very atmosphere that allows us the conditions to have life on Earth that is also where we are changing that chemical balance, and thus it is warming things up. And the other sort of pivot and pause, besides sort of a sense of wonder and sort of an understanding of that big global picture, is just gratitude for the people that I get to work with. I mentioned the Nice Check Network. This was the brainchild of former chair of my department, my primary department, Phil Landrigan, working in concert with a lot of people over a decade to get this network funding stabilized, and which I now have the honor of co-leading with Maida Galvez. You see her also there in the front row in a black t-shirt. And we have 7 centers across the state, from Buffalo to Albany and down through Hudson Valley and out to Long Island. And it is a great honor to work with this team, as well as other people with the other hats that I wear. But this is one of my most proudest efforts and day-to-day activities. So this network, as I said, stretches across the state, and one of the efforts that we're doing as we educate providers and think about that prepare and adapt mentality is to think about how climate health risks affect different parts of the state. And some of these also, air quality was certainly an issue in multiple parts, not just the city, in early June, but some of these are slightly heightened risk in regionally. So that ranges from mosquito-borne disease to harmful algal blooms, certainly extreme heat days, and we know that impacts rural areas as well as urban areas. Tick-borne disease is on the rise. We think down here about coastal flooding a lot, but inland flooding, and sort of pluvial and fluvial flooding, as they call it. So not just flooding associated with storm surge, but also upstate that's near rivers, but then also just from sheer cloudburst events, which are now also on the rise, sort of rapid rainfall events. So that's to give you sort of a spectrum of the many things that we're thinking about and what we can incorporate into our clinical work and how we can tell these stories. And when we incorporate things into clinical work, we always want to give people actionable items, both the clinician, so they feel like they have something that they can provide and they're not just asking questions and worrying people. But this is, we develop what we call prescriptions for prevention, which have key messages around different environmental exposure topics. And we've made this series around extreme heat and safety tips, and we've tailored them. We have 4 different ones of these RX for prevention on different subgroups within children or for pregnant people. And this is part of our continued effort of integrating environmental health into clinical care, and then specifically thinking about it with a climate lens. Another one of my great joys is working with trainees. Teresa Herrera led this study. We do a lot of work looking at heat effects. So thinking about hot weather days and how they put people's health at risk. In New York City, we found that young children were at risk of going to the emergency room, higher risk of going to the emergency room during hot weather. And that while it wasn't as much infants, thankfully they had sort of probably more social protections and were not spending as much time outside, particularly when it was hot. But those younger years, those preschool age years, were the ones where we saw the most signal going to the emergency room when the weather was hotter. And this is important to think about sort of what are the mechanisms behind that. Are they getting burned on the playground, literally, like with touching hot surfaces, or is it because of their physiology combined with their behaviors of sort of predisposition to dehydration, and then maybe just not as a heightened awareness on the part of the caregivers. And so this was led to more questions, as research always does, about why. And then subsequently, Blaine Gurma dug into that a little bit more and unpacked sort of a finding that we had found seen on injury, and was able to start to tease apart sort of who was going, and actually found and corroborated with older age groups that they were also going to the emergency room for injury at heightened rates during elevated temperature days. But working with trainees is also an opportunity to let them follow their passions, and particularly think about how when we study climate change, we also have a responsibility to then in turn educate on it, but also thinking about the justice aspects. And so this is a flyer from a presentation that Blaine gave for a group out in California. And then I wanted to also say that Blaine and Teresa, that you saw on the previous slide, founded a group called the Black Child Health Working Group here in our department during their time with us. They've both gone on to doctoral studies now. But that working group lives on, and that is sort of an internal educational, we do teach-ins with our community to try to understand some of the drivers of disparities in health for Black children in particular. Another student-led initiative is the Climate Change Curriculum Infusion Project, which has brought climate change and health content into 6 different courses across the first 2 years of the Sinai medical curriculum, and now in 10 lectures across those. And this is just infusing a few slides into pre-existing talks. And then we approached the lecturer, we got access to the slides, and then we sort of figured out where we thought it would fit and got permission from the course directors, and then approached the lecturers, the faculty who were giving the lectures, and asked if they would be willing to incorporate this. And Christian Cayone, who's now an emergency med resident, came with a degree from Hopkins in sustainability and said, we need more content. And so it's really been these trainee-driven initiatives that I have been able to use the momentum of to try to bring more climate content And so the way we do that is, as I said, through a couple of slides, and I just wanted to give you an example as we're thinking about different ways to incorporate this into clinical care. So in the ASM course, Art and Science of Medicine course within Sinai, when they teach about social history, we offered the following slide, thinking about vulnerable populations, but specifically thinking about heat wave days and disaster planning, and questions that you as a clinician can think to ask patients, which have actionable items, for example, around low-income subsidies for electrical bills. There are programs that you can orient patients to so that their electricity bills are subsidized, so that they hopefully not only have air conditioning, which is another program that the city runs that you can sign patients up for, but then also have the funds to be able to pay electrical bills. Con Ed also has a program to prioritize people who have medical life support equipment for reinstating electricity when there are power outages, and so helping connect people who need those services to the right places to where they can sign up is an important actionable item. But then we're also thinking about how climate change curriculum can be infused into resident education. And so in 2021, Dr. Phillips Bourne led this article that I co-authored on the essentials for resident education in the Journal of Academic Medicine. And we proposed a curricular framework for all residency programs, not just primary care, but with a focus there, with evidence-based links to core ACGME competencies, with suggested learning formats, assessment strategies, and then specific content. There's 4 or 5 pages of learning objectives that go with this, with some spelled out suggestions. And we really felt like this was a big step forward in creating space for climate change curriculum, enabling educators to do that. And it was warmly embraced, particularly by pediatric residency directors, and which is the primary care specialty that the authors are most closely connected to. And this was quickly followed by another article led by the same Becca Phillips Bourne, focused on practice framework for pediatric providers. So thinking a little bit farther down the pipeline. And this article details practical education that can be provided to both trainees, again, and their mentors, immediately used in screening, as I've sort of talked about, history taking, health promotion topics, management plans, and tweaking anticipatory guidance during thinking about well child care in this case. But a note that we feel strongly, basically everyone that I work with, that climate education must be grounded in climate justice. And we know that the health effects of climate change really have a larger impact on low-income communities and communities of color. And that's because of this environmental racism legacy that really lives on in many of our policies and practices. And education on the solutions also have to be grounded in this concept in order to reduce the historic health inequities and injustice, and then I would add recognize the ongoing ones. And so part of that is telling the story of structural racism, really reframing that. So when we talk about the vulnerabilities of Black and Brown populations, really grounding that in understanding what are sort of the neighborhood factors. What does it mean when we say SES or socioeconomic position, and sort of from a research lens, really unpacking that and doing that both certainly thinking about that in our clinical practice and where there are points of intervention. But for me, also with the hat that I wear as an environmental epidemiologist, thinking about that and even how we frame our questions. And it's a work in progress. It's certainly something that I recognize as a long learning arc to sort of figure out how to disentangle, because it's important to study the disparities and to use, in some cases, race as a variable, but also to do that with caution, and to make sure that we continue to interrogate that and not stop at identifying the racial disparities. Within the family medicine world, there is a rising star, a former student of Becca Phillips-Bourne, who I mentioned earlier. Dr. Harrison Goodall is now a family medicine resident at UPenn, and it's combining this fundamental environmental and climate change education with education on climate justice in this new newsletter that he has launched called Elemental. And that QR code will take you to the Substack to sign up for the newsletter. And at Montefiore in the Bronx, the current social peds chief resident, Chase Moon, is also educating his peers like Dr. Goodall. Chase has built and implemented and is in the process of evaluating a climate change curriculum for pediatric family medicine and internal medicine residents up at Monty. And he started these sessions last February. They'll conclude next month. And the residents participate in 90-minute sessions broken into 2 parts. He's tailored that to go with the flow of the specific residency. So he's using small group based, case-based format for the family medicine and internal medicine residents by their request, and a lecture-based format for the pediatric trainees. And one example of that 4-part curriculum is this mental health curriculum, where he identifies these learning objectives, linking mental health and climate change or natural disasters, also thinking about eco-anxiety more broadly, thinking about how that can be tailored around anticipatory guidance, and then identifying resources, and there's increasingly lots. The very last one on the list on the right there, Coco's Fire, is actually a children's book, and there's several of these now that are both to promote literacy, promote environmental literacy, but also think about coping strategies when there are disasters that have affected communities, and how we can specifically bring storytelling sort of as a coping mechanism for children to help process those events that have happened. But climate education and advocacy go hand in hand, and Chase is really demonstrating this. So after completing the educational session, some of the residents were able to go with Chase to a state legislative rally as part of a statewide grassroots coalition, New York Renews, to advocate for climate change legislation that was at the time being considered in New York State. New York State is a leader in climate policy, but then there's a lot of folks who are making sure that the way it gets implemented also continues to, the intention of the law is there, but how it gets implemented also still aligns with some of the justice initiatives. There's other trainee climate education advocacy opportunities. Chase was able to author a blog for the American Academy of Pediatrics. Often they reach out to our team, and then when we know that there's trainees who have things to say, we can connect the dots. There are community partnership building, like the Cap the Bronx, the Cross Bronx Expressway project. And so this is the picture here is an Einstein medical student was able to go up and advocate on this. And this is that's Senator Schumer. And we also have residency advocacy training that's led by Clean and Healthy environmental advocacy group based up in Albany. So lots of opportunities. And then as part of Nice Check, our statewide network, we have an EH Scholars program, and this has been going, we're in our 3rd cohort now, and the scholars have ranged from people working in community-based organizations who are not clinicians, to a range of clinicians at different stages of career. These are both faculty members, one based in Buffalo, the other in Albany. And for the first time in this cohort, they are focusing on climate change, one on climate change curriculum within the medical education at Albany, and then within the residency, the pediatric residency in Buffalo. And we have potential more openings for additional scholars outside of Sinai. So I'm happy to continue that conversation with folks if anyone's interested. And then I wanted to specifically address some of the concerns that people raise when they think about climate counseling directly with patients. So Caroline Wellery, Andrew Lewandowski, and Cheryl Holder co-authored this article in the American Family Physician, thinking about climate change communication. And I hope that I've made the argument that it is relevant in terms of how it impacts patients, and sort of anybody has potential reasons to think about and prepare for climate change. But specifically, I wanted to address two concerns, like, do we have enough time to incorporate it? And the takeaway is that what's recommended by communication experts and people who've thought about sort of the jam-packed clinical visit is consistent, simple, clear, and tailored messaging that's less than a minute. And there's some beautiful scripts that are now out there. Colleague here in the department, Emily Sinai, has also authored an article thinking specifically about climate communications and role playing, and showing some communications and how it can be seamlessly integrated into counseling. Reimbursement and federal standards. The takeaway is that there are people who are actually working on this to sort of try to steer the big ship and incorporate, change the standards at the CMS, which hopefully will influence downstream reimbursement payers, and so maybe make it not only more feasible but more sustainable to implement this into clinical practice. And to this last question that some people raise, is whether or not it's how it will be embraced by the patients, whether or not this is a welcome conversation. And Andrew Lewandowski in Wisconsin did a beautiful little study in practice with a short script around introducing the concept of climate change and talking about how energy choices can make a difference in both local air pollution and also long-term climate change. And that this was important because, and he reoriented it to the child's health, particularly around respiratory health. And this was warmly embraced by families. The bottom line there is, as I've tried to lay out, the majority of medical organizations are backing this. And really, doctors are already experts at talking about controversial topics or things that are potentially prickly topics, whether or not that's around sexual health or gun control or a whole bunch of other things that are even end of life. And so this is a terrain that we can apply some of those skills to navigate. There's also opportunities local. So in the clinical setting, start today. But if you want to meet people, a really neat group of people who are working on this, We Act for Environmental Justice, based in Central Harlem, is a long-standing, incredible organization that has their membership meeting on the first Saturdays of the month. So that's, or second Saturday. So that's this Saturday. But then they also have a climate justice working group that meets virtually and maybe also in person now. And that QR code will take you to that if you're interested in getting involved there. It's been really great. I'm in the home stretch here, and then I look forward to the conversation. Specifically, I would love to think with this department and people who are interested about funding opportunities to grow these educational initiatives. And so I did a little bit of digging into who has what grants and who's offering what money. And two of the ones that jumped out are the Picker Gold Graduate Medical Education Challenge Grant Program, and then the Macy Foundation has several grant programs that some of them are sort of small seed money to get going. Some of them are slightly larger programs. And then the RWJF really depends on their specific funding calls. But then there's also a lot of institution or professional association specific awards that can sort of catalyze initiatives as well. The AAP Catch Grants is one of them, for example. And as I've alluded to all along, it takes a village. These are our partners for the Nice Check network, both within healthcare, within government, and then within community organizations. And it is really a large group that is wonderful to work with. And it takes all of us to do this. So gratitude to Chase for some of the slides that I used in today's presentation. Also, this is a partial list of trainees that I've had the pleasure of working with over the last 10 plus years. To some, this isn't even a comprehensive list of my mentors, as well as the many funding sources that come in to support this work and keep this academic career going so far. So thank you all.
Thank you so much. Let's get us back. So if you have questions, you can put them in the Q&A, and we'll try to address a few of them. I have a couple to start off with. I probably had about 30, but a couple things sort of jumped out at me. One was the slide you showed about the percentage of carbon emissions that come from the US. And it's about the same as the population, the world population that's in the United States. I would have thought that we were a much bigger polluter than the average. But
we are. That was just the health sector.
Oh, that's just the health sector? Oh my God. Oh, that makes it even worse. So that also brings me to, like, how do you bring this stuff home? So you talked about anesthesia being a big thing. Is that something that we're working on with the anesthesia department here so that we can actually model things and not just talk about them, but actually like say, hey, there's a modeling here, just like we would want to try to see how could we model something in relationship to, beginning to talk to patients about things and whatever. I mean, the best way to implement and make education real is to have faculty model the things that are actually, being brought up. So just curious about that. And then, I guess the last thing I'd ask you is, so where do we start? What would be the first thing that you would do with a department that really has not done anything in this area yet? What would be your toehold into this, if you were just wanted to start something? And thank you so much, because this was it was a great presentation.
Yeah, thank you for that. And also for sort of naming the elephant in the room in a sense, because sometimes many times I give this talk, and then the question is sort of what's happening at Sinai? What are we doing? And there's lots of conversations that need to happen. I don't actually know within anesthesiology where we are. I know because of Jody Sherman's work at Yale that they've made big strides. I have heard on presentations out in California and Kaiser, they have done incredible. It's basically swapping out desflurane with another, like there's simple changes that can be made, and it might have already happened here at Sinai. I don't know. I know at NYU they've done it. So there's even hyper local examples, and I know that often, as you said, faculty can be a mentor can model it for students. I also think that other health institutions can model it for our own, and that sometimes that's a motivation.
First toehold.
So yes, I think there's tons of potential there. I will also say that Emily Sinai, my colleague in this department, is a thought leader, a national thought leader on sustainability, and she has helped advance the institution a bit, but that we have a ways to go. And increasingly, there's amazing models around the country of who's doing what. And people who are taking notice of that, like medical students who are doing the planetary health report cards now, which are sort of bringing, again, in some cases, catching people doing well, and other places sort of motivating them to do better. And Sinai participated in that for the first time this year. So that might be a further motivation. Your other question, well, one was, where do we start? Is that the next one I should take?
That would be
Um,
great. What are your thoughts?
yeah, well, as I try to demonstrate in the talk, a lot of this work has been student driven. And I think that on the one hand, that's sort of a practical strategy for me because of limited bandwidth and building out a medical curriculum was not my funded activity. But when Christian came and said, this is, what I want to do, and then I could sort of figure out how to make that work as sort of in my mentorship role with him, and that he could carry that. And so it's strategically opportunistic in that way. And I think that approach within the department certainly Chase Moon, who's the resident at Monty, has been an example of that. I got connected to him 2 years ago, and he has never looked back. But it was a matter of just these small little connections, and then he's run with it. And so we edit his slides, for example, but he's carrying it, but it's his passion. And so I think supporting people, knowing sort of what the menu is, and as I tried to demonstrate, there's opportunities every time you see a patient in a clinical setting, and there are ways that we could further support those conversations. And what NiceCheck is doing is generating these RX for prevention, these tools that are meant to simultaneously equip providers to have the messages right there, but also to, in some cases, literally be something you hand a family or that you can get to them electronically that has these actionable items. And that's usually more geared toward protecting health, not necessarily cutting off the flow of carbon emissions, which is also important, but sort of a different, less of a role within the clinical, in the clinic or in the exam room. So my short answer is to sort of follow people's passions and where they already have areas of influence. When we interviewed faculty who had been somehow involved in our climate curriculum, we explored with them how they got involved, we interviewed last 2 summers ago, we interviewed Sinai faculty who were involved in our curriculum, but then we interviewed a cohort from around the country who were involved in climate and health curriculum. And when we asked them how they got involved in it, the theme that emerged from that was some kind of proximal learning. Like many of them had a brother who was an environmental advocate or something. And so there was some sense of, this is important to people that I love. And even if it's not in my wheelhouse, and I'm going to stretch a little bit to try to figure out how to do it. And so it's in that same kind of theme, I think, the people we love being this community that we're working with, or those that we're committed to training, and figuring out sort of how to support their passions.
So we got a bunch of questions piling up here. So
okay, go ahead.
Red, did you want to go first?
No, I mean, I have some thoughts, but let's let the other folks ask their questions, and then.
Okay, so Dr. Amin, who's our inpatient director, what are the Sinai initiatives towards net zero carbon? Are there considerations at the senior leadership level, minimizing the use of plastic products, shifting towards solar and green energy? That was one. Thoughts about
Sinai
that?
Sinai did sign the mayor's challenge a number of years ago, but I think Sinai's has a long way to go. And I understand that healthcare operates on a narrow margin, and there are certain electrical grid constraints that Sinai is up against. And so I'm cautiously optimistic that Sinai is going in the right direction. And I think they could do more. In terms of, there was a question about plastics, for example, there are some very cool initiatives. And I think that this is an area where we do have a sustainability office. And Christine McNeilis, I believe her name is the coordinator for that. And then, so there's some institutional commitment to trying to advance these initiatives, but there are some very cool swap outs, for example, around, going from single use devices to autoclavable ones that also have a return on investment. And so, this is that field, clean med. There's a conference every year. There's a whole field around sustainability. It's a huge growing field, and there's lots of things that we could do to be more on that bandwagon, I think, as an institution.
Another question is, how do you feel like physicians can help push back against nationwide environmental insults, deforestation in Atlanta, interstate pipelines? I feel like these directly affect the health of communities, but I'm not sure what I can do about it.
Yeah, well, the slide, I think someone was asking for the working group slide. So this is what I just shared again. So I find a lot of hope and solace by working with groups like We Act, who are not only like incredible organizations, but also just bring together people who, I think it's normal to have anxiety around this issue. It's normal to have grief around sort of the environmental destruction that's happening. There was a reference to the deforestation in Atlanta, and then also is probably maybe thinking about Cop City and the conflict that's happened there and the killing of the environmental activist. And so one, to be able to name that and share that grief, but to find people that are working together on those issues. And then connecting the dots between something like the idea of sort of increasing militarization or enlarging law enforcement, and how that is directly connected to health disparities, and connecting the dots to climate change with those things. And so acknowledging our interconnectedness in that way.
Well, you saw the disruption that took place at the US Open around environmental protests. I mean, people are really, the people that are passionate are putting themselves on the line like people have for many other issues.
They are. And I also saw the interview that Coco Gauff did afterwards, and I really appreciated that she acknowledged that it was disruptive, but she didn't malign them. And I think she understands that they actually probably have a lot of common values.
Red?
Yeah, thank you. This was really excellent and inspiring. I guess one of the things I'm wondering about is the structural changes that can come from some of the regulatory agencies. So, for example, a lot of initiatives that come through the Joint Commission and regulatory bodies, I'm wondering if there's any work being done on using that as some leverage. And I guess another comment is the role that community health centers can play, and the fact an organization like Chicane's and some community health organizations, I'm not sure how those organizations are currently involved, but that might be another opportunity. But I'm just, at Beth Israel in the 90s, they were talking about burning plastic, incinerating hospitals' garbage, and that was a major source of dioxin in the environment. And just, getting hospitals to change their waste disposal plans, and to what extent could that be a regulatory issue, where it's not a matter of if and when, it's like you need a timeline. And so that was really sort of along the lines of policy and getting these large institutions to respond.
I appreciate that question. I think there is a lot of potential for joint commissions, or just CMS, for how they drive both clinical practice and healthcare industry practice. And there's some very neat people working on this. One of the ones that I'm closest to is Aparna Bol, who was pediatrician from Ohio, but now works at the White House Office on Climate and Health Equity under the leadership of John Balbus. And they are passionate about this issue, and also trying to be very strategic, understanding that the office is basically begging and borrowing to be funded in the first place and has no teeth. And so they're trying to think about exactly what you're saying, sort of like who does have the teeth and how can we influence that. And so they're working on a number of initiatives And looking forward to hearing an update on that, because I last connected with her when she was pretty new in that role. And so that is in the works. You mentioned community health centers. So part of their initiative was a pledge, again, depending how you feel about pledges. Maybe not as strong as we would like, but a pledge is a first step. And Sun River, is that the community, one of the
Yes,
network?
we're familiar.
They were a signatory to it. And so I don't know them, but I would love to
Well, we
to hear
can-
more about that.
yeah.
And maybe that would be a place to start a conversation of sort of what
Right.
are they really doing?
Well, kind of along those lines, I just, we can play a role much like we do around voting with our patients, is not only getting the information that you're describing in climate counseling, but climate activism with our patients, that, this is really, it's not a role typically we play as physicians and healthcare workers, but I think it's a really good opportunity in our interactions to say, not only this is what you need to do for your family, but this is what you can do as a citizen. And just curious if there's any effort in that regard of just being able to step up the level of engagement with the people that we care for.
So I'm seeing in the chat that Suzanne Callahan, who's our federal connection, says that the National Association of Community Health Centers has a climate change working group. That might be a great connection for us. I would just add that we committed in our new facility in Kingston. I asked our architects to put together a plan. It's a brand new facility built from the ground up to get us the highest LEED certification that we could. And it turned out it was about a 50% upcharge on the construction costs. And so one of the things that, it occurs to me is if it's going to always be more expensive to do the right thing, it's going to be really hard to make this change. So we ended up getting LEED certification, but only at the a more primary level. And it just, even that was required additional funding in order to do. So there's a lot of work to do in terms of, where we put our resources. I mean, people shouldn't be penalized for doing the right thing. They should be rewarded for building the right kinds of facilities and using the right kinds of energy and everything else. And I know there's some incentives for that, but it was not enough to really do what we would want to do. And I think we really, that's a huge issue, because community health centers are being built in the lowest income communities around the country. And that would be a great start, a great way to link up the community health center world with some real environmental action.
I think that's one of the specific initiatives within the office, the White House Office on Climate and Health Equity, is thinking about the building codes that are under the jurisdiction of CMS. I don't know all the levers that they're pulling, but they're thinking about how to drive that.
I think we have time for one more question. Question's about the international, the overuse of resources in the U.S. compared to low-resourced countries, causing droughts and problems with agriculture and everything. So, any comments on the international scene?
Yeah, I mean, I think, thank you for bringing that up. Certainly the impacts of climate change are probably 90% outside of this country. When I talk about it, I try to emphasize the impacts here, because those matter, and they're so disproportionate in who they're influencing or impacting. But that is even more exaggerated globally, and the vast majority affect low-income countries, particularly in Africa and Southeast Asia. So absolutely. I mean, and those are the countries that have contributed the less. They have had the least energy demands over our 50+ history, 100-year history of industrialization, and now are disproportionately being impacted by the particularly extreme weather events like droughts.
Great. Well, our time is up. our pledge will be to continue to work with you and see what we can do to implement some of these things in our own programming and in the work that we continue to do as we develop more health facilities and other things. I'm sure that there's a lot that we could do very quickly at the institute and at the department level, because it's not something we've really engaged in yet. So this is a great kickoff for us. Thank you for your time and a great presentation. And everybody have a great day.
Thanks, everybody.
Bye.
Yeah.